would like to welcome our participants today and attendees in another webinar for SAMS about COVID updates. Today we'll be talking about COVID vaccine updates, COVID-19 vaccine updates. This webinar will have a CME accredited by Stanford University. We have distinguished faculty members today presenting during this webinar. The format will be a 25 minutes to 30 minutes presentation, and we'll have question and answers from the panel, answered by our panel. I would like to introduce first our moderator, Dr. Yasser Tarabishi. Yasser Tarabishi is a physician at Metro Health. He's assistant professor of internal medicine at Case Western University in Cleveland, Ohio. He's also the director of clinical informatics, research informatics at Metro Health. Dr. Tarabishi.
Thank you. Welcome, Dr. Maldonado, Dr. Khairulla. Thank you, Fuad, for bringing us in. So it's my distinct pleasure, I'll introduce the two panelists, to welcome Dr. Maldonado to this discussion. She is an infectious disease and pediatric specialist at Stanford with numerous academic appointments, professor in pediatrics infectious disease, an epidemiologist with a lot of kind of storied research in this space, including HIV and polio, and it seems like a natural tendency towards the pandemic as it's happening. So we welcome her expertise here. And Dr. Khairulla, who usually requires no introduction. He is a critical care physician and intensivist and an associate professor at the University of North Dakota and an educator, a well-known educator. So welcome both. And Dr. Maldonado, we'll start by you presenting some slides, if you could, about 25 to 30 minutes. And I'd like to direct everybody to the Q&A button at the bottom. So as the moderator, I'll be collecting your questions and I'll be collating them, and we'll try to generate a good discussion, which should be the latter third of this hour. So without further ado, Dr. Maldonado, take it away.
Thank you so much for that introduction, and thank you everybody for attending today. I'm going to give you an update on COVID vaccines. And of course, these updates are probably going to change pretty rapidly as time goes along. So I will give you some general information as of today, which is December 16th. So let's start with understanding a little bit about coronaviruses, and this will be helpful in understanding the vaccine itself. Now, there are 7 known human coronaviruses. 4 of them actually just cause seasonal colds. And we know that there are 3 additional coronaviruses that have mutated to produce more severe disease: SARS in 2002 to 2004, MERS, which is still endemic but low level in parts of the world, not here in the US, and now SARS-CoV-2. The spike protein of SARS-CoV-2, here shown in this cartoon, these yellow spike-like projections, is really important in understanding the way this virus functions, because this spike is one of 3 surface proteins, and it is it actually has binds to a receptor on the human host cell. Now, there was a spike mutation which is likely to have occurred in a transition from being a bat virus to an intermediate host, it's unknown, and then to humans, which likely occurred in 2019 and allowed this virus to spill over into humans. That is, this virus generally didn't infect humans, but the spike protein mutation allowed it to bind to ACE2, the angiotensin converting enzyme 2, on the surface of many of human host cells. And so this is where the binding occurs in the spike protein, which has an area called the binding site. And so this is a really critical piece to understand. Now, it turns out that antibodies to this spike protein are really important in preventing binding and therefore infection with the virus. So if we can make antibody, it turns out if we can make antibody to the spike protein, and more importantly, make neutralizing antibody to the spike protein, then we can interfere with the ability of this virus to bind to the human host cell and produce infection and disease. So that's really critical. And that's how these mRNA and other vaccine viruses work. Now, I'll talk a little bit about the different vaccines and then about how this particular Pfizer vaccine works now, and a tiny bit about Moderna, because we are going to be reviewing the Mrna vaccine tomorrow and over the weekend with the CDC and the FDA for potential approval. So you can see here that we follow, at least I follow, the New York Times vaccine tracker, because it's a really nice place to see where the vaccines are. And you can see that right now there are 2 vaccines that are being considered in red here for phase 3 consideration. The Pfizer BioNTech vaccine, which is an mRNA vaccine. It was recently, as you probably know, last weekend, approved by the FDA for emergency use. And tomorrow, the Mrna vaccine, which is also an mRNA vaccine, will be reviewed by the FDA and voted on for consideration for approval in a very similar fashion to the Pfizer vaccine. Now, there are 4 other vaccines that are also very close to being reviewed in the next year, we hope. One is the Johnson & Johnson vaccine and the Oxford AstraZeneca vaccine. Both of those are adenovirus platforms that they use adenoviruses as the backbone, and then they have spike protein genes inserted so that they can produce the spike protein, and then the body can make neutralizing antibody. The other 2 vaccines that are coming hopefully in 2021 for clinical trials in the US will be Novavax, and not listed here, but also included will be the Sanofi vaccine. And both of those are protein subunit vaccines. So those are traditional protein subunit vaccines, and those will be investigated in the US in phase 3 trials also beginning next year. Now, let me talk about the Pfizer vaccine, because that's the one that is now approved, as you know, and for which the country is actually in the process of pulling out their vials from frozen boxes, and will be starting to be, then are already been vaccinating as of Monday all around the country. So the proposed indication from the FDA was prevention of SARS-CoV-2 infection of disease caused by the coronavirus SARS-CoV-2. Now notice we don't have an indication for prevention of infection, because we don't know yet whether this vaccine prevents infection. It does prevent disease, and this was approved for people 16 years of age and older. And the dose level and regimen are 30 micrograms of the mRNA component given in 2 doses at greater than or equal to 21 days apart. The vaccine comes in 5-dose, multi-dose vials, although we've just found out today that some of the vials actually have 6 or 7 doses in them. So they got really filled up pretty full. And so there is an opportunity to actually use actually a little bit more vaccine per vial than we thought. But the conventional dose is supposed to be 5 doses per vial, and you have to use them within a few hours. They have to be given, each vial once opened has to be used within a few hours after opening. Now we know, and I'll talk about mRNA in a bit, but mRNA inherently is not stable at room temperature. And so because of that, it needs to be stored at ultra cold temperatures. And this particular product needs to be stored at around -70 degrees centigrade in order to maintain its activity. Otherwise, the RNA will degrade. Now, here's how mRNA vaccines work. We know that the mRNA in real life, in the human cell, in any host cell, there is mRNA that is manufactured in the nucleus and is transported out of the nucleus into the cytoplasm. There in the cytoplasm, mRNAs have a nucleic acid tail that attracts ribosomes. The ribosomes attach to the mRNA and they translate in proteins from that mRNA signal. That's what happens in the normal human condition. Now, what's happened with this vaccine virus is that mRNAs are put into lipid nanoparticles. So the nanoparticles are fat nanoparticles that surround the mRNA, which codes only for the spike protein, for the full spike protein, nothing else. And these nanoparticles are injected and they're taken up by the myocyte. And the lipid actually is what gets them taken up by the myocyte. And then they are then uncoated. The mRNA stays in the cytoplasm and is basically ribosomes then attached to the tail of the mRNA and then begin translating the spike protein. So you make lots and lots of spike protein. Now, one of the benefits here is that because it's mRNA, you wind up having the mRNA immediately degraded after the ribosome is done translating it out. And so it's degraded, it doesn't go into the cytoplasm, it doesn't go anywhere else, it really just breaks down. And then the other thing that happens is the human host cell then displays the spike protein on its surface. So therefore, what you see, what the body will see, what T and B cells see, what the immune system sees, are spike proteins that are foreign on the surface of this infected cell, and the body then makes immunity and makes neutralizing antibody to that spike protein. So therefore, what we see is that you are not getting live virus. You are getting a protein that, a piece of RNA that sits in the cytoplasm, makes spike protein, gets an immune response, and then degrades. After inoculation, as I mentioned, this process occurs, and we don't see any live virus, nor does mRNA enter the nucleus. I just want to emphasize these key points because I know that there is some anxiety among individuals because we have never had an mRNA vaccine that's been licensed for use in humans. But the studies have been done in the laboratory, in human tissues, and now in individual people. And we know that these key points here have been demonstrated to occur. And this is really very encouraging and leads to much more confidence around the safety of these vaccines. Here is a schematic drawing of what I just described. So here's the lipid mRNA, the lipid capsule with the mRNA inside getting engulfed by the cell. The mRNA is here, and then the ribosome comes along, attaches, creates lots of spike protein. You then see spike protein on the surface, and T and B cells then come along. The T cells will destroy the infected cell. The B cells will come along and make antibody to the spike protein. And then you also elicit memory cells as well, so that later on, when you come in contact with wild type SARS-CoV-2 virus, you will then activate not only your immune cells, your antibodies, but you will also activate active T cell cytotoxic cells. So in doing the clinical trials, the endpoints were disease. So these were people who were enrolled. There were about almost 44,000 people who were randomized either to placebo or to vaccine. And in order to qualify for being a case after vaccination, the person had to have received their vaccines, and they had to have one or more of these symptoms, either fever, new or increased cough, new or increased shortness of breath, chills, new or increased muscle pain, loss of taste and smell, sore throat, diarrhea, or vomiting. Plus, they had to have a validated PCR that was sent to the central Pfizer laboratory. And this was the primary case definition of a case of COVID in the trial. And what you can see here is that when you look at the outcome, there were essentially 170 people out of these 44,000 people, almost 44,000 people, who developed a COVID disease based on that case definition I just showed you. 162 of those occurred in the placebo arm, and 8 of them occurred in the vaccine arm, leading to a 95% vaccine efficacy with confidence intervals that were fairly tight, that is between 90 and 97% efficacy. This breakdown was similar across age groups, so that the efficacy was still very strong and very high by age groups, and also based on comorbidities. I didn't show you the slide here, but when you looked at sex, you looked at comorbidities and ethnic groups, there was no difference in efficacy in any of those groups. When you look at vaccine efficacy estimates, you can see that after 1 dose, there was still about 52% efficacy after 1 dose, but clearly you needed the 2nd dose to get good efficacy. And as I showed you earlier, I mentioned earlier, race and ethnicity you did not see variations in efficacy based on race or ethnicity. So the primary conclusions that the FDA and made and CDC were that the individuals without prior infection had 95% efficacy after 7 days after dose 2, and that the observed efficacy, this was a separate point, was greater than 93% across age, race, ethnicity, and at-risk comorbidity subgroups. Now, when you look at safety, these are the diaries from people who got the vaccine based on age. And you can see here that pain at injection site was quite high. So mild in the green and moderate in blue was quite high after dose 1 and dose 2 in about 2/3 or more of people compared to the placebo. So you will see pain, but very little redness or swelling will occur locally. When you look at systemic events, you see that in younger people, there were more systemic events than there were in older individuals older than 55, but they were still more frequent. Up to 40% of people had symptoms like a mild flu-like illness. For example, fever in a small group of people, about 10%, but up to 40% had fatigue. Some people had headache, chills, muscle pain, and joint pain. Some had that on the day of injection, but most of them had it on day 2, and a few people continue to have symptoms 48 hours after injection. This is looking at overall bodily system organ class and problems, and you can see there was no difference in adverse effects or adverse events recorded based on whether the person got vaccine versus placebo, except for general disorders. And these were things like the flu-like illness that I mentioned. So these were the fever, headache, myalgias, and arthralgias. And then you see here, overall, when you look at large system disorders such as infections, cardiac, nervous system, neoplasm, injuries, there was no significant difference between the vaccine group and the placebo group. So in further studies, the company plans to do additional work to look at persistence of immunogenicity. That is, how long will the vaccine protect against disease, against symptomatic disease, and also continue long-term safety studies. That is to see whether there are long-term safety signals that might reflect very rare safety events that may not have been picked up in the thousands of people who were already studied. They were also going to see whether boosters can be effective as well. In case we do need to have boosters, it would be helpful to know how well those boosters work. There are also going to be additional studies in children. Those are going to be starting soon, probably in the beginning of the year of 2021. They're going to study additional follow-up of pregnant women and immunocompromised individuals. And as well, they are going to be developing 2nd-generation formulations that can be more stable at at warmer temperatures. And then finally, they're starting to think about ways to co-administer the vaccine with influenza if necessary. So I want to just mention just briefly that CDC has proposed a phased rollout of vaccines. So currently we're in phase 1A, which means that we're going to be giving vaccine to healthcare professionals as well as long-term care facility residents. And phase 1B, we think may start in January or February. We'll be discussing that with CDC on Sunday to give to essential workers, and more information about who those essential workers will be decided on Sunday. And then finally, phase 1C will include all adults who don't fit in the other categories with who are over 65 or those who have high-risk medical conditions. There will be additional phases rolled out over time, so that we think that by the spring, we should see vaccine available for the entire US population. Now, this is what the CDC has defined for the current phase 1A as healthcare personnel. And these are individuals who work in hospitals, long-term care facilities, outpatient clinics, home healthcare individuals, pharmacies, emergency medical services, and public health individuals. Long-term care facility residents include those living in skilled nursing facilities, assisted living facilities, and other residential care. And it's estimated that this population overall makes up about 24 million people in the United States. So what's next? Well, we already saw that both of the companies, Pfizer and Mrna, have filed emergency use authorizations. The FDA approved the Pfizer vaccine on December 11th and deployed it on the 14th. Approximately 30 million doses will be available in December. And tomorrow, the 17th, the FDA will review the Mrna vaccine. And we assume there will be, if everything goes well, and we've already seen the data for this vaccine, we assume that the deployment will be very similar, and that approximately 20 million doses of that vaccine should be available in December in the United States. So this is the overall schematic of what we expect will happen over time. That is, initially, we'll see phased increases in allocation of vaccine and then stabilizing out over the spring and summer. And then after the summer, we will see continued vaccination sufficient to meet the demand in the United States. And what does the future hold? Well, for treatment of infected individuals, we hope to see additional therapies, including the combination therapies that we have now and additional ones that are being studied around the country and around the world. And prevention from vaccines through herd immunity, although we know that the degree and durability of the immunity has yet to be determined. Additionally, we want to follow vaccine adverse events, and non-pharmacological interventions such as masking and social distancing will need to be continued for some undefined period until we can figure out if this vaccine indeed does protect against infection and transmission. And so I will stop there, and thank you so much for your attention.
Thank you, Dr. Maldonado. That was great. We already have a couple of questions, so I'd like to kind of move into this discussion portion of the hour. Unless Dr. Hill, do you have anything you'd like to add before I jump into some of these specific questions?
Just wanted to add one slide, if you don't mind, if you can share.
Please.
You know, the question is whether this study was good enough to detect adverse events associated with this vaccine or not. And this will show you the power of the study and how many participants should we have in the study. And let's see on the left column here, what you see is the background rate in general population of any event. Let's just say Guillain-Barré. Guillain-Barré is in the United States of average 5,000 people per year. That means probably we are in between 1 in 10,000 to 1 in 100,000. It's exactly 1 in 65,000 people. Now, if we administer a vaccine and that vaccine causes a higher rate of this disease in the community, and we have 3 different categories here: 5-fold, 10-fold, and 100-fold. If we have a disease in the community that is, the prevalence of that disease is 1 in 10,000, all what we need is 16,000 participants in that study to detect 5-fold higher rate of that disease. Of course, if that vaccine causes much higher rate, we need less participants, all the way down to 500. If we go to 1 in 100,000, in order to detect 5-fold higher, we need 160,000 participants. If we go to the 10-fold higher, we need 53,000. And then you can see the number on the side. If we have an adverse event that is, or a disease in the community that is occurring at 1 in a million, at that time, in order to detect 5-fold higher, we need 1.5 million almost in the study. 10-fold is 500,000. 100-fold is 23,000 only. The Pfizer study included 44,000 people in it. And the Moderna, I think it's around 30,000 people in it. So you can see that with this study, with the power of the study that we have, the power of it to detect 5-fold higher is only if we have a disease in the community that is occurring at 1 in 10,000. With Guillain-Barré syndrome occurring at 1 to 65,000, I think we'll be able to detect it only if the rate of Guillain-Barré goes 10-fold higher than what it is in the community right now. For much more, for rare diseases, it would be very difficult to detect unless we have a 100-fold increase. This is why it is important to continue monitoring the adverse events after deployment of the vaccine in the community. And for those who already were vaccinated, you can see that we are registered through the VSafe, through the CDC, where they're monitoring. You get text messages on a daily basis to monitor any adverse events, and they will go on forward to detect any rare, unexpected adverse events that may occur with this vaccine. Thank you.
Thank you for that. Yeah, so maybe we can start with a little bit about some of the study design, since that's where we launched the discussion. I see a couple of questions here, and I'm going to do my best to relay what I've gotten in the chat group and through my phone texts. There's a couple of questions about the number of cases in the study. So perhaps the fact that the study was done when the prevalence of COVID was not as high as it is now. Does that cause any concern about the study results, is the question being.
Actually, the study was started in July, and I think they wrapped up, they submitted their data on November 20th. So we were already, we spanned a couple of surges, actually. So we spanned a surge and then a dip and then another surge. So I guess what the person may be asking is whether the characteristics of the individuals might be different. And that's a good question. We did have some individuals who came in through the latest surge. But I think what you heard from Dr. Corella is really correct, that we really need to take advantage of all of the post-licensure surveillance that happens through CDC, FDA, and through the company will have to continue to do that. So we have, I didn't show that slide, but there's many existing mechanisms for surveillance, as well as new mechanisms that were set up just for this vaccine and this disease. So absolutely, we need to continue to follow these populations and people who are vaccinated to make sure we detect any signals, as we do with any other vaccine over the long term.
Awesome. And Dr. Khalil, please feel to jump in. These are not questions directed to anybody in specific, but I'm just trying to generate a healthy debate here. We know that at least in the Pfizer study and probably also in the Moderna study, I haven't looked at it myself, immunocompromised and immunosuppressed patients were excluded. And obviously there's a lot of physicians here in this group that cater to patients with these issues, whether or not it's compromised or suppressed. Outside of, I guess we can comment A on the data that's available, which is probably not a lot. And then B, what is the expectation based on, historical precedent for this subgroup of patients?
So actually I haven't had a chance to pour through the Moderna data the same way. That's my assignment for this evening. I started to look at it, but the Pfizer vaccine did enroll, I don't know if any of you remember, but they started off enrolling 30,000 people, and they did exclude anybody with underlying conditions. But then they went back and started enrolling 14,000 more patients. And those 14,000 additional patients were people with comorbidities, some with underlying immunocompromised conditions, people who have, for example, hepatitis C, HIV, and other conditions as well, hematologic and oncologic underlying disease, and children as young as 16. So there was a mix of patients in that subgroup. Although it didn't make up, a large proportion of the population, it did make up all of those groups made up those 14,000 additional individuals that were enrolled later on in the trial. So at this point, the FDA and the CDC looked at the data and they felt that there weren't any concerns at this time around safety for people with immunocompromising conditions. Now, obviously, one needs to discuss with their own provider whether there may be some issues that people need to be aware of. So the mRNA issue, I think, is reasonably well settled at this time in terms of potential transfer of the mRNA into the nucleus and integration into, well, first of all, it'd have to be reverse transcribed back into DNA and then integrated. And there's no mechanism that has been demonstrated for that to occur. But the other would be whether or not there are any safety signals for people with underlying immunodeficiencies. And that has not been identified as a concern at this time, given the numbers of people studied. The only concern might be at this time whether or not somebody is acutely immunocompromised to the point where their ability to mount an immune response might be compromised. But certainly, of course, we'll be following those patients, including the other group, of course, that people ask a lot about are pregnant women. And we did meet Saturday morning. I met with CDC and with members of ACOG, the American College of Obstetrics and Gynecology, and they had placental and immunologic experts who did not feel that there was any reason to be concerned about any safety issues at this time with the vaccine, and felt comfortable endorsing it, and actually have endorsed it in their own guidelines, as well as from the Society of Maternal and Fetal Medicine. So there are about 20 or so pregnant women in the Pfizer trial, and there are also some pregnant women, I can't remember, it's a small number, in the Mrna trial. Although it was an exclusion criteria, there were some women who became pregnant. But as far as I understand, from as of a week ago, they hadn't delivered their babies yet, so there wasn't any information about safety signals. So that's going to be followed as well.
If I could tease out some of that balance that you brought out. So the issue of efficacy of the vaccine in the context of an immunocompromised suppressed state versus concern for adverse events in the context of the state. It almost sounds like, I don't want to put words in your mouth, but the concern is primarily the latter, that they're not going to respond.
Yeah, I think that's the concern now. Of course, we have to, know more about what happens in these populations. And as you can imagine, and it is a risk benefit. So the question is, are these patients at higher risk for complications of COVID disease from the wild type virus? And we do know that there are data that demonstrate they can be at risk for complications. And could this vaccine be helpful in that population? And so overall, the risk-benefit ratio was felt to weigh in favor of vaccination.
Okay. We'll move on to some of the response data. The degree of the efficacy was particularly striking in both the Moderna and the Pfizer vaccines. What's your gestalt about that? I mean, we know plenty of prior, the usual vaccine data that we get for flu and other illnesses, much lower numbers. And so, is this that first study where it always looks better than it actually is? Are we expecting that to attenuate over time in the real world? What do you think drove that? Or is it just the incredible technology of mRNA vaccine that happened to crescendo at exactly the right moment?
That's a great question. I think, we're going to have to learn more about this as time goes on, but it's striking. As you may recall, the original agreement with the FDA from all the companies, the vaccines had to have at least 50% efficacy with a lower 95% confidence interval of 30%. So the bar was pretty low here. And this vaccine, and so did the Mrna vaccine, really far exceeded that number. The lower bound was, as I showed you, was 90%. And so why did this happen? Well, first of all, you are introducing mRNA straight into the cytoplasm. You're getting a large amount of production of spike protein directly in the cell. It's being expressed on the cell surface. Perhaps there's a fair amount of expression on the cell surface. We also know that lipids serve as adjuvants, so there may be an adjuvant effect here as well. And by the way, people were worried actually about too robust an immune response. That is, are we going to see what you see with COVID disease? That is a really robust cytokine response, for example, or inflammatory response, or other adverse immune response. And in fact, some of the data that were demonstrated by the company demonstrated a very strong Th1 weighted response, which is really more, but yet blunted downstream, and a robust innate response that was actually blunted so that there was not an antagonistic inflammatory pathway. So the Th1 response coupled with a blunting of that continuing on to signal highly inflammatory downstream impacts was seen. So at least from the laboratory perspective, the immune response looked very well weighted, and it's possible that that combination did really well. And we don't know that maybe the adenovirus vector vaccines will come up with the same degree. And so as we know, in many ways, I mean, my own simple way of thinking, this is almost like the hepatitis B surface antigen response, right? You just need antibody to the surface antigen to get protection. And perhaps because it's a single protein that you need to develop neutral antibodies to, that may in some ways also make it easier. So if you think about pertussis vaccine, for example, which has many different antigens that need to be you need to develop immunity to protect against disease. That's much more complicated, and it's not as simple to have good vaccine efficacy there. We're talking about a single protein and a single, and obviously multiple epitopes, but a single protein that's easy to produce. So those are just theories. I don't know whether this will hold up over time.
It's very interesting. Another concern that some of our viewers have here is these reports of allergic reactions came up in a couple of questions. And so your thoughts on that?
Yeah, and I think, you heard Dr. Corella talk about the, risk of different diseases such as Guillain-Barré, transverse myelitis we heard about for AstraZeneca. The risk of anaphylaxis to any vaccine is always present. But in general, the risk of anaphylaxis to a vaccine, either to the excipients, usually it's to the excipients, or generally to the excipients, is about 1 in a million, 1 to 3 in a million. So this is actually, if you look at the trial, you probably won't pick up an anaphylactic reaction just given the number of people who are vaccinated, because the Placebo did not have the excipients. It was just saline. And in addition, there were no anaphylactic or anaphylactoid reactions identified in the trial. But as you all know, last week, there were 2 individuals in the UK who suffered anaphylactic reactions and 1 additional person who had an anaphylactoid reaction, which is different immunologically speaking from an anaphylactic reaction. So it's unclear what's going on with that. And then, of course, you saw today that there was 1 patient in Alaska, one vaccine recipient in Alaska, who developed what looks to be an anaphylactic reaction. Now, I have not had time to look into that at all. I've only seen what's been reported in the media. But there is an agency at CDC called CISA. They are they look for adverse events around vaccines, and they study them in great detail. So whether generally these tend to be less common adverse events. And they are busy at work now reviewing the cases, trying to get the data from the UK to understand what happened there, what happened to the 1 patient in Alaska today. And so we'll know more about that. But in any event, any body, any society that recommends vaccination always includes a statement that any vaccine that is administered must be given in a place that has epinephrine available in order to be prepared for a potential for an anaphylactic reaction. And that's true for any vaccine.
Yeah, actually, a couple of us, I know Dr. Kroll, I think you got it a couple of days ago, the Pfizer vaccine.
Yeah, I got it.
I had mine today. So that's why I'm sitting there feeling my shoulder, trying to see if it's consistent. So we're nice to you, Doc. So
well, tell us your firsthand experience. This is valuable information.
It's very anecdotal, I'm sure, and probably don't want to scare anybody. No, I'm fine, Dr. Hidla. How are you?
I'm doing okay so far.
You're past the 2-day mark, although we're more worried about the second dose, right? The second
I had
round.
no systemic symptoms at all. It's only local pain in the left arm that is only very mild. And similarly, all my colleagues who were vaccinated had no systemic symptoms.
Yeah.
One of the physicians who had corona in the past developed some fever and weakness, which we thought may be related to some immune reaction that he had in the past with the corona.
That crossed my mind as I was getting the shot. I was wondering if I had been exposed and maybe this was going to reveal the tragedy that I had.
Yeah, interesting.
Yeah, because I was staring at the EpiPens while they were administering. They had them all lined up.
Good.
And my favorite part about it was actually the timer. So I don't know if this is standard, but this is new to me. You know, they had a waiting area after the vaccination where you sat down. They had a 15-minute timer. And it felt like you were in timeout because you couldn't go anywhere. They said you cannot leave until 15 minutes are done.
If you allow me, I want to ask a question, Dr. Maldonado. Do you have any idea about the mutation that happened in England, southeast, I believe? Is it involving any of the areas, epitopes, that may be a reason why this vaccine may not be effective?
Yeah, you know, it's interesting. I haven't been able to identify where on the spike protein that which epitope that affected, but there was another earlier mutation identified in a strain circulating in Texas earlier this summer, and that seems to be the predominant circulating strain as well. And that occurred in the spike protein as well. It doesn't seem what that previous mutation has done, and it may be the same for this current one, is it turns out that the spike protein is a triplet, and it has to sit. It's not a very when it wants to attach to the cell, it's not super stable on the human cell, even though it can attach now. It's not very stable, so it'll hit the cell, the ACE receptor, and it may not always bind. Turns out that the mutation that happened, that they identified in Houston when they looked at the mutation itself, it stabilizes that triplet. So it's much more likely not to fall off of the ACE2 receptor. So it's thought, at least for that mutation, that it just makes it easier for once a virus has gotten near the ACE2 for it to actually attach and then be allowed to be endocytosed into the host cell. And so as far as I know, with all the data that we've observed, there has not been any evidence of increased virulence, but potentially increased infectivity. And that is the predominant circulating strain in the US. I don't know much about the UK genotype or what the phenotypic expression is, but I imagine it could be similar. Now, one of the things about mRNA vaccines, the reason I think they came out first is that this is a platform that's been studied for a while, but there was just never a lot of interest in investing in it. So this goes to show you that when there's a lot of money and you have a platform that's available and you have billions of dollars at your disposal to play it out, this platform may have languished for some time because it's been experimented with for quite a while. They've been looking at it for a number of different types of antigens. And it's actually very easy because you just have to use mRNA. You just have to make the code, the nucleic acid sequencing and encapsulate it. And obviously the two products, the Mrna and the Pfizer, have proprietary lipids, nanoparticles. But it's not as hard, for example, as creating an adenovirus vector and taking that through all of the animal studies or even the protein subunit platform. So those are, as you know, those are taking a while to develop. So it very much in that way, if there is a mutation that let's just say happens in the receptor binding domain or in another really important immunogenic epitope or neutralizing epitope, you could theoretically manipulate the mRNA product every year like you do with the flu and adapt it so that it can and I don't think that's going to be the case here. We don't see the same segmented genome, but I think what may happen is there may be selective pressure because of the neutralizing antibody, selective pressure on the antigens on the surface of the virus. And so even though this is an RNA virus, so on the one hand, RNA viruses tend to mutate faster than DNA viruses, but this particular RNA virus has a corrective mechanism to modify mutations. So it doesn't mutate as rapidly as other RNA viruses, which mutate on the order of 10 to the -4, basically. So this is a little less frequent, but still in all, there could be pretty strong selective pressure to see mutations along that protein. So all that to say that it's possible that we will need to get vaccinations over again, either because of mutations potentially, or more likely based on what we know about the seasonal coronaviruses is that they come back every year. So about 30% of all seasonal cold viruses are coronaviruses, and people can get reinfected over and over again. So the question is, how long will this immunity last? Will it be a year? Will it be 2 years or longer? And then there's another little factoid that isn't a true fact yet, but it's rumored. So I will spread one little rumor. And that is that there was a big epidemic, a flu pandemic in the late 1800s, in the 1860s. And it was thought to be a pandemic influenza. It was really bad. It killed millions of people. And now people are thinking that that may have actually been one of the human coronaviruses, that is now a seasonal virus that actually evolved and entered the human population in the late 1800s. And the reason they think that is not because they have genetic sequences, which it would be nice to get, but because if you look at the characteristics of the genealogy of one of the current human seasonal coronaviruses, it seems to have arisen in humans around the same time as that pandemic. and the symptoms of that pandemic are very similar to what we're seeing today. So, so it may be that these viruses show up more often than we think. And we think they're going to keep showing up because we've already had 3 new horribly fatal coronaviruses in 20 years. So I would keep my eye on the coronavirus family.
I would like to remind our participants that they can get the CME through Stanford University. There is will be a link in the chat if they go to claim the CME from Stanford. It's a free CME if they need them. And then I have a question for Dr. Khairallah. You said one of the physicians who had coronavirus, who had the COVID, got vaccinated. I thought this is an exclusion criteria. Do you think that we're going to start seeing people getting vaccinated at this time, even though they had COVID-19?
Well, I think the priority for those would be the last. We don't know how long the immunity is going to stay in the body. And we know that not every single person who's infected with the vaccine would develop adequate level of antibodies at the same time. So it is advised that anyone who would like to get the vaccine, even if he had COVID in the past, would get it. But in terms of priority, it should not be on the top of the list. However, that specific physician is traveling overseas and won't be able to get the vaccine till he comes back in a few months. So he thought he would be vaccinated before he leaves.
Just to weave the antibody discussion in, is there a role in looking for neutralizing antibodies before vaccinating?
You know, we generally don't recommend that. I think I may have mentioned that before. It's too expensive. It's hard to do. In general, for public health purposes and for population implementation, it's generally not. It's not recommended because serology is cumbersome, and in fact, for this purpose, we would want to measure neutralizing antibody. There is a kit now that's approved for detecting neutralizing antibody, but I'm not sure how much it would be helpful. I think, you know, what we heard was correct, that, you know, everyone should probably be vaccinated, even if they had disease in the past. I think it's really just an issue of how much vaccine is available for those who weren't infected before. And we don't know, for example, whether people were infected before unless they say they had symptoms or had a positive PCR. We know, for example, that 40% of people who are infected are asymptomatic, and 40% more have mild or moderate symptoms that don't require hospitalization. The other thing is there are a number of studies now coming out around the country and around the world looking at antibody after infection. And it turns out that, at least for now, what has been found, that the more symptomatic the individual is, so for example, people who are hospitalized, people who are ventilated, have a much more robust immune response than people who have mild disease. And the antibody for those with mild disease is either non-existent or it disappears very rapidly. So if you measured antibody, you may not know that that person had immunity. And in fact, what you might want to look for are evidence of effector memory cells, which, you know, that's not, you know, a garden variety assay that you would do on every single person. So I think it would be helpful to get those studies done for research purposes so we can understand the kinetics of immunity. But I don't know that, I think there can be some instances. For example, I understand that for to go to China right now, you need to have evidence that you have antibody to the virus now. So, so some places may need to require it for one reason or another, but not for routine use.
Dr. Hill, are there any people that, given the data we have now, you would not recommend the vaccine to?
I think anybody who has severe anaphylaxis at this point, I would be concerned. And individuals who are going through, currently going, say, induction chemotherapy, or you know, a major shift in their immune system. For example, if they're starting on new immunomodulator therapy, I would not start them right away until they were stabilized on their regimen. mostly because of concerns about the inability to determine whether they had an adequate immune response.
So I am a gastroenterologist with busy practice with a lot of patients on immunomodulators, but they're stable on their immunomodulator. They're not starting, and I'm getting this question frequently. Is it safe for them to do it, or do they wait for more safety data? Is it going to work or not with the anti-TNF agents, for example? Do you have any you or Dr. Khairallah on any specific about immunomodulators if they're stable on them?
Yeah, do you have any, see if you have any information?
No, actually, not more than what we know from the study. In practice, different groups are looking into this and see what kind of recommendations they're going to make. To me, it seems that it should be okay. I don't see any reason why they should not get it. But to answer the question scientifically, we don't have the data to support what we say. Similarly, for the pregnant woman also, it looks like it's doesn't have any side effects on them, but the study excluded pregnant women other than what you mentioned, Bonnie.
Yeah, I mean, there's a question here which touches on that. The NEJM article seems to have more restrictive exclusion criteria. Is that just a sub-study? I mean, you mentioned some other cohorts that were also in the overall trial.
Yeah, so the original study included 30,000 people, and then they expanded the study after consulting with the FDA because I think they realized, well, I don't know, I can't guess why, but I imagine they wanted to expand it to be able to get a broader indication. Because in the real world, as Dr. Azraq pointed out, there are a lot of people on immunomodulators. There are a lot of people who will, be immunocompromised in one way or another. We need to understand race and ethnic differences if there are any. So the second 14,000 people may not have been included in a lot of that analysis.
Interesting. So I don't know if you guys want to, we can keep going. There's a couple more questions. I don't know if you have a little bit more time, Dr. Maldonado. It's crossed the hour now. I'll bring in we'll move a little bit towards some of the other vaccines, if you guys don't mind. You mentioned a little bit about the probability that the inactivated vaccines might be just as efficacious, that this is just a function of the virus we're up against. Trying to keep aside the issue, objective assessments of the quality of data and the openness of science in other places. There are people that are, we have family members, for instance, in other places that are being offered, for instance, the Chinese virus, right? The Chinese vaccine, or some alternatives. What's your sense on your gist of the safety for some of those, or the efficacy? I know they've, in terms of mass volume, right? They've vaccinated much more people than we have for our studies here.
Yeah. I unfortunately, since I have no idea, I mean, I see the data you see. We just see the top line data, right? We just see what's published in a website, or you read indirectly. I can't really tell you what might be going on. And also transparency is important. So we don't know what else is going on that we're not finding out. Are they really tracking, with surveillance and all of that? Maybe they are, and it would be great to hear that. And it would really be nice to see the data, but I really can't comment. If the vaccines platforms are similar, then I imagine they would all be just as safe. But it's very hard for the CDC, FDA to really know what's going on with other products because we don't have access to the same data. We don't always have access. Sometimes we do, but right now, as you know, the Russian vaccine was approved before it went into trials. So really wouldn't have known much about that particular platform. So yeah, it's hard for me to know. I haven't seen the data. I just happen to know that I've looked at the Pfizer and the Mrna data, and I'll have access to the other data as well.
But I have access to some of this data from my colleagues in United Arab Emirates. The Chinese vaccine mainly studied in UAE and Bahrain, and I think other countries too, but this is where I have information from. And The system that they have is a good system where they can monitor for side effects, and so far, there are no major side effects. The efficacy of the virus, the vaccine is 86%, so it's a little bit lower than what we have with Moderna or the Pfizer vaccine. But it's been actually given to more than 1 million people so far around the world because of their emergency use authorization that happened after the second phase, not necessarily something that we would do here in the States with this. And there's some anecdotes. Like there's a meeting in Germany that happened that there's one attendant had coronavirus, total of 99 people in the meeting, 70 of them were vaccinated and the remaining were not. And none of the vaccinated people acquired the infection. However, around 8 or 9 of the non-vaccinated people got infected with the virus. But this is a small number anecdotes. We don't have anything published like what we had with the other vaccines from the States.
Oh, that's good to know.
Can you, Yasser, go over some of the questions of our audiences? And
I've been kind of weaving them in and out. Some of them we touched on briefly, things like more questions on people with rheumatologic disorders, on chronic immunosuppressive therapy. We touched on that. There is another question more recently about this 21-day period versus the 28-day period for the booster. I think Moderna's got the 1-month follow-up, right, versus the 3 weeks.
Yeah, so the Pfizer vaccine is 21 days, the Moderna is 28 days, and I have no idea why they're different. It's, just their dosing interval that they decided worked best for them.
Right. Do you think that there's some mechanistic rhyme or reason for those intervals? Does it matter if you do it 2 months later? I mean, do you lose that?
I don't know. We don't know any of that yet. I mean, it's too early to tell. So we'll find out more. I mean, this is what happens with every vaccine. People want all this granular information that you just can't say. You just have to wait and see. Somebody will get it. They'll write a case report of 100 people who got it and did fine. But right now it's, we have all the data that's kind of, the good news is that all the data that we have is all out there for everyone to see. The bad news is that we can't say much beyond that unless we, there's no reason to suspect that interval should make a difference really. But, I think it's just the way they ran their studies.
There's somebody concerned about the germline, can this affect fertility or offspring in pregnancy or otherwise?
Well, you'd have to postulate that the mRNA would somehow travel into the germline. I mean, I suppose it's possible, but I think it would be very unlikely. And I'm not sure what mechanism that would have in terms of inducing infertility, if it's just producing spike protein. I mean, there's nothing else going on there unless you had some kind of an inflammatory response, which we have not, again, vaccines generally do have normal inflammatory, you do get a sore arm in any vaccine, and we haven't seen infertility as a side effect. That does come up quite a bit, and people have studied that for every other vaccine and have not seen any increased incidence of infertility in vaccine recipients in general for all vaccines.
Awesome. I think those are most of the questions. Some of them we answered in different formats that have come up again. Dr. Hulla, do you have anything else to add or point out?
I'm okay.
All right.
Well, I'm glad did you both get both your doses, or you just got your first dose, I imagine, right?
Yeah, I got my dose 1.
Good, so you're 50% protected.
although I've been tracing myself on the Kaplan-Meier curve, and I don't like where I am until I hit day 12. And I'm going to be in the COVID ICU in a couple of.
Yep, day 12 is the magic day. That's right. The virus, one of my immunology friends said the virus read the textbook.
So it's funny because you say that. Those of us who have taken the vaccine, it seems almost, this debate came up today, it seems almost like it's a selfish thing to do. It's the opposite of masks. You wear masks to prevent other people. You get the virus so that if you get it, you don't notice, right? You still might be able to pass it.
Right.
I know that's a question that came up somewhere in the chat too, but the answer is we don't know. We don't know if
Yeah.
you're vaccinated and you get a minor infection that's mildly symptomatic or asymptomatic,
Right.
whether or not you can give that to your family. So by me getting vaccinated, I have not protected my family. And I still, this also came up in the chat, we still have to wear the masks. We still have to do all these precautions, the distance.
Well, but on the other hand, here's the other, so that makes sense. But I've worked with polio viruses for decades myself. And the problem with polio is exactly that. You don't get paralyzed, but you can easily infect other people. So that's why everybody had to get vaccinated against polio. Now, the difference here, I think, is again, this is all hypothetical, but perhaps with immunity, you might have a lower viral load. And then perhaps if you're careful, you will be less likely to transmit to others than if you hadn't been vaccinated. So that's potential. I mean, so it's possible that vaccination could actually reduce transmission. So it'll be really exciting to see whether that's the case. And the way you'd have to do that, obviously, is, I mean, I guess you could do a challenge experiment and see if somebody gets infected after vaccination, and then you measure viral load. I don't think, I mean, that's not going to be something done here in the US. Or you could just, as you mentioned, a conference where there's infected individuals and half the room's vaccinated and half the room's not. You could see whether those people transmitted, the people who were exposed and got vaccinated, not only did they not get infected, but did they not transmit to their family members or something like that. So,
and let's not forget that all what we need is to bring the R naught to less than 1.
50
with
to
that-
70%. Yeah. So that's the other point, is you don't need, it's not like measles. With measles, you need herd immunity in 95% of the population. So the herd immunity you need here is related to the R naught. It's a formula. It's 1 over the R naught. And so basically you need about between 50 and 70% of the population, depending on what you think the R naught really is, between 50 and 70% of the population to be immune in order to just statistically reduce the risk of perpetuating outbreaks. So that's not too bad. I mean, 50 to 70% is better than 95%. So maybe we can get there.
And that R naught is actually related to the culture of the community. So in Arabic cultures, it could be easier to transmit because people get closer to each other and the houses are close. So that would be different than what it is in the American culture here.
Yeah, absolutely.
Yeah, as an American-born, Arab, I can tell you that the amount of hugging and kissing always profoundly made me so uncomfortable.
Yeah, well, my family is from Mexico. We're a Mexican family, and I tell you, it's tough not to hug. We hug everybody. It's just it's hard not to do that.
Well, it's almost an offense not to. So that's
absolutely.
I'm being nudged about this final question, and I know that you have a history. You seem to study a lot of health disparities, and obviously you suggested that in the last sentence. The plan for getting the vaccine out. A lot of people in this group do medical missions area. There's a lot of at-risk people, and I have to tell you the one thing that I experienced when I was getting the vaccine. I was thinking two things. One, I was thinking, I am so privileged. I mean, sure, I have to work in the NICU with COVID patients to get this, but this is an extreme privilege, and it's the epitome of science, and it's amazing. It's remarkable how far we've come, decades of development to get to this point, right? But at the same time, there's so many people around the world that are never going to see this, and it's a uniquely first world problem. And I think I guess I'm asking here if you have a thought or what's your thought on how we reduce this particular disparity? And this is a disparity that we inevitably see within our own country, let alone, outside of our own country. There are people that, one of the questions brought this up. I mean, a lot of the US population is not interested in getting the vaccine, and that tends to be higher concentrated in minorities and folks that are,
so my other role, in addition to this work, my other role in my pre-COVID life is I'm Senior Associate Dean for Faculty Development and for Diversity. So a lot of my work is around this area of how to provide a more equitable and diverse and inclusive environment in the academic medical setting, as well as reaching out to our communities of color. We, as you know, most of our clinical trials are not done in communities of color. the results of clinical trials may not be the same for people in different racial and ethnic backgrounds. And yet those are the groups that are least likely to want to participate as well because of mistrust. So I do think this is a really important area, and having familiar key leaders who people trust are really important, because there's there's a historical pattern here of not telling people the truth and not treating them fairly. I also work, my research is in global child health. So I work in Sub-Saharan Africa. I've worked primarily in Southeast Asia and Latin America. So I've always seen disparities, and I grew up I was born in the US, but I lived in Mexico for part of my life. And, I grew up seeing these disparities all the time. And, it is something that we're seeing in this country as well, and more. And I do think that we need to make an effort to make sure there is equity. That's something that I think has come out loud and clear with this virus. I think all of the disparities that we had before were always there, but this has just highlighted them. And you're right. I mean, we're going to see. So if I have a really interesting slide, which I obviously want to show you now, but it's how many doses of vaccine per capita are already committed. So the UK has 5 doses per capita. The United States, let's see, I think Japan and one other country the EU have 2 doses per capita committed, and everywhere else in the world has less than 1 dose per capita available. And that's just vaccine. That's not testing or masks or anything else. So I've worked in the Democratic Republic of Congo when we had Ebola outbreaks. I've worked in other places where we had active cholera infections, and of course in all of the displaced individuals. This year, as you know, last year was a record-breaking year for displacement, and it's really difficult to know what to do other than to bring care to those populations. But we have to do a better job of taking care of all of our populations. And I think one of the things, hopefully, that we learn from this is that we are all connected. So somebody somebody got infected by a bat on the other side of the world, and now we all have to deal with it. And maybe this is a way of us understanding that, we can't ignore what happens on the other side of the world, because it will affect us one way or the other, whether we think it does or not. It will absolutely affect us. So that's a great point to make.
Right, and it's really, the world is connected, as we saw with COVID. You cannot let any part of the world not covered, monitored, or intervention. SAMS in 2013 have to intervene with work with a lot of local and international organization, because the polio start coming back from the displacement when happened in Syria in 2013 and 14. And it was a massive effort that has to be done on the ground with multiple international and local and regional players to prevent the polio from getting, again, a major issue. And even under the war circumstances, their volunteers were going from door to door, house to house, giving the polio vaccine in a lot of areas of Syria that was not, there was no access to it.
Right. And these were people who had better vaccination programs than anywhere in the world. And now all of a sudden we had to go back and start again because of the disruption of all of the normal health systems. Absolutely.
Right. And the concern was this going to be moving with the displacement of this population into other parts of the world. So you cannot say this is a problem is isolated in one area. And it's a massive work it was in 2013 to reestablish the immunization process.
Yeah.
It was really an honor. I think we went above an hour. So I would like to I would like to thank all our participants who stayed with us so far. It's still a 68 with us on, even though it's beyond the hour late in the East Coast. Thanks for our moderator, Dr. Tarabishi. Dr. Khairallah, it was always a pleasure to have you, an honor to have you, always a wealth of knowledge. Dr. Maldonado, we're really happy, Bonnie, to have you. It was amazing presentation, and it's a lot of wealth of knowledge. And I hope everyone enjoyed the evening with us tonight. the CME again through Stanford University. It's probably going to be an hour and 15 minutes if you attend the whole session. You can take a screenshot if you want right now from the screen right now, how to claim your CME. And I wish you good night. Hopefully we will have another future COVID updates from SAMS on different topics and updates, because this is something that's going to be with us in addition to other scientific updates in the future. Thank you very much, all of you.
Thank you.
Thank you.
Good
Good
night, everybody.
evening.
Good evening.